Hello everyone, my name is Raymon Grogan. I'm an endocrine surgeon and chief of endocrine surgery at Baylor College of Medicine in Houston, Texas. And I'm going to be talking to you today about scarless parathyroidectomy and in particular the transoral vestibular approach. I have no relevant disclosures for this talk. Just in an overview, we're going to review primary hyperparathyroidism in terms of its diagnosis and treatment, talk a little bit about the demographics of the incidence and prevalence of hyperparathyroidism, and then go into the advantages of the transoral approach for parathyroidectomy, and then finish up with a demonstration video of the transoral technique. You can get in touch with me through email or Twitter anytime you'd like if you have any questions about this talk. So let's start out with the general approach to how we diagnose and work up and treat primary hyperparathyroidism. So realistically, we can break this down into three pretty simple questions. And if you know these three questions, and you know how to answer them, you can work up and treat about 98% of all primary hyperparathyroidism cases. So number one, does the patient have the disease? Number two, does the patient need an operation? And then number three, what type of operation can we offer this particular patient? Those are the three questions. Pretty straightforward, actually. So question number one, do they have primary hyperparathyroidism? This is a biochemical diagnosis. So in the classic case of primary hyperparathyroidism, we have an elevated calcium and an elevated parathyroid hormone level. If those two things are elevated at the same time, it's diagnostic for classic primary hyperparathyroidism. There are other types of hyperparathyroidism, such as normal calcemic, which means normal calcium with elevated PTH, and normal hormonal, which means elevated calcium with normal or high normal PTH. Those are less commonly seen, but they are variants that you should be aware of. So once we've made the diagnosis with the biochemistries, the next question we ask is, do they need an operation? Because not everyone needs an operation for parathyroid disease, but the vast majority of people will. So the first indications for operation are people who are symptomatic. Anyone who has these symptoms should go for surgery. That includes osteoporosis, a history of kidney stones, abdominal pain and constipation, or these symptoms that are a little harder to define, things like insomnia, lethargy, memory changes, bone pain, things like that. These are all considered symptomatic patients, and all of them should go for surgery. There are, however, people who are asymptomatic, meaning they don't have any of those symptoms. But there are several other criteria that have been identified that would say that people will benefit from surgery if they have any of these other things. This includes a serum calcium level greater than 1 point above the normal value, a urine calcium greater than 400 milligrams in 24 hours, a creatinine clearance of less than 30%, any previous history of hypercalcemia that caused them to be hospitalized or was a life-threatening episode of hypercalcemia, any patient who can't or won't continue to follow their calcium levels to make sure that they don't become extremely high or have hypercalcemic crisis, and patients under the age of 50. And that's because if you're at 50 years of age and you don't have symptoms, the likelihood of you developing symptoms over the next 30 or 40 years is pretty high. So once we've identified that they do have hyperparathyroidism, we've identified that they do need an operation, the final question then becomes, what type of operation can we offer for these patients? There are two basic types of operations. There is the traditional four-gland exploration, where we go in and look at all four glands. And then there's what we would call a focused parathyroidectomy, where we go in and remove only one single gland and then check the parathyroid hormone levels in the operating room to make sure that the other three glands are not over-functioning at that point in time. Essentially, this is the only time that imaging studies play a role, and that's to identify whether or not you can do a four-gland exploration or a focused parathyroidectomy. Imaging studies don't make the diagnosis. Imaging studies don't tell us whether or not the patient should have surgery. All the imaging studies do is help to localize the gland. The two imaging studies we recommend are an ultrasound, because the ultrasound will also look for thyroid nodules that may need to be worked up prior to the parathyroid surgery. And then it also can look for the parathyroid. And then a CT scan, which is a parathyroid-specific CT scan, also called a 4D CT or parathyroid protocol CT. It's pretty clear now that the CT scans are the most sensitive and most specific imaging modality available. We moved away from sestamides. I don't really order those much anymore because the CT scans have gotten so good at identifying these abnormal parathyroid glands. So the way this works is if both the ultrasound and the CT show one single parathyroid adenoma in the same spot, then we would consider that to be localized. If the two imaging studies are not concordant, meaning they don't show the same gland or don't show any glands at all, then that would be non-localized. So if it's non-localized, you have to do the traditional four-gland exploration because you have really no idea which of these glands may or may not be abnormal. And in the vast majority of cases in non-localized imaging studies, it's going to be four-gland hyperplasia anyway. If it's localized, especially if you have a CT that's very clearly localized with one single gland, the likelihood that this is a single gland disease is very high. It's over 95%. So that's why we offer the focused parathyroidectomy in those cases. We go in, remove the gland, check the levels. As long as the hormone levels return to normal, we're done. The key to this is that with the localized parathyroidectomy, it can be done either with the traditional approach through a small 2-centimeter incision or with the transoral approach. And that's what we're talking about here today. So now that we know how to work these patients up and how to treat them, let's talk a little bit about the demographics of hyperparathyroidism. So in the United States, you can see here, this is the prevalence and this is the incidence of primary hyperparathyroidism in the United States. This is taken from a paper that was published in 2013, and it was looking at a population-level database in California, which is a multi-ethnic group of people. Essentially what they found was the highest prevalence was in the Black community, followed by whites, and then the lowest prevalence was in Asians. And in incidence, the estimated incidence in women was around 65.5 per 100,000 per year, and it's lower in men at 24.7. Now, when you compare this to the South Korean population, you can see that the estimated incidence in combined men and women is 7 to 14 per 100,000, which is much lower than that 65.5 per 100,000 population in the United States. And you can see here, these are the actual numbers of parathyroidectomies done in South Korea per year, roughly hovering around 500 per year. This is also in comparison to Hong Kong. These data are a little bit older, but what we can see here is that the number of operations per person, when you compare Hong Kong to South Korea, is almost double. So Hong Kong does double the number of parathyroidectomies when you look at it by a per person basis. But it's still a much lower rate of parathyroidectomy than in the United States. So you can see here that there was maybe 150 done, maybe 200 done in Hong Kong in the year 2002. And like we said, 500 or so per year in South Korea. You can compare that to somewhere between 20 to 100,000 parathyroidectomies done in the United States each year. So clearly, we do a lot more parathyroid surgery in the US than what is done in most other countries. But that doesn't mean that the transoral approach is strictly limited to the United States. There's still hundreds of these surgeries being done in other countries, which can significantly increase the number of transoral procedures being done if they're done via the transoral route. So what are the indications for transoral parathyroidectomy? Essentially, it was like we said earlier, if the parathyroid is well localized with those two imaging studies, then we can do it with the transoral approach. Currently, we're not recommending doing it for things that are not well localized, and we're not recommending it for four-gland explorations. It's not that it technically can't be done, it's only that it takes a lot longer to do that, and clinically the trade-off just doesn't seem to be there just yet because it just takes too long to do it that way. So that includes anything that's genetic, any genetic reason for primary hyperparathyroidism, because most of the time that's going to be four-gland disease. Anything that obviously is not localized will not be done transoral. And no secondary or tertiary hyperparathyroidism. These glands tend to be very inflamed. They oftentimes can be stuck to the recurrent laryngeal nerve. Again, technically, can it be done transorally? Yes, but they're quite challenging operations, and clinically the trade-off just doesn't seem to be appropriate at this point in time. So once we know what those indications are, which we just described, we can then figure out how many people are actually eligible for the transoral approach for parathyroid surgery. We did this study back in 2019 and looked at 3 separate academic endocrine surgery practices in the United States and looked at 1,000 consecutive patients that came through those practices and then applied those inclusion and exclusion criteria to those patients to understand how many people would be eligible for the transoral approach. And here's what we found. You can see here in this red box that essentially 57.9% of all primary hyperparathyroid cases that came through our clinics were eligible for the transoral approach. That's over half. So in the United States, that translates into a lot of opportunity there. Almost 58,000 parathyroidectomies are likely possible to be done each year in the US via the transoral approach. But in South Korea, that means at least 250 cases a year. In Hong Kong, probably 100, probably even more, because those data that we had were quite old now. So you're talking about in these countries in particular, hundreds of cases of transoral cases that could be done if you were doing the parathyroidectomies via the transoral approach. And of course, we're not even discussing any of the other countries outside of the US, South Korea, and Hong Kong, but clearly there are parathyroidectomies being done there. So you're talking about increasing the total numbers of transoral opportunity there by a lot if people started applying this to parathyroid surgery. So are the clinical trade-offs really there? In other words, by doing the transoral approach, are we doing something that's clinically relevant and clinically valid? So we know that the complication rates are similar between transoral thyroidectomy and traditional thyroidectomy, but we didn't know that much about for parathyroid. So we actually have now collected 100 consecutive transoral parathyroidectomies, and we've reviewed all that data. These data are under consideration for publication. So I don't have a whole lot of it to share with you. I just want to share with you this one slide. But the bottom line is complication rates are similar between the two. Amount of pain postoperatively is similar between the two. Infection rates are obviously very low with the transoral approach for parathyroid, just like they are for thyroid. So the one remaining question is, does it take too long? The bottom line is what we found that the median operative time was 112 minutes, but this was for the entire time period. So 112 minutes obviously is an hour and a half, close to 2 hours almost. But once the learning curve was achieved, those operative times were reduced by 50%. So essentially, what we saw was a parathyroidectomy can be done in 1 hour or less via the transoral approach. And in my personal practice, where I've probably done about 100 of these now, for example, I did one today in under 20 minutes. So once the learning curve is achieved, this can definitely be a very fast, very quick operation. And so clinically, it is a valid operation because complication rates are the same, pain is the same, recovery time is the same, and it can be done in under an hour. So there's no reason not to do the transoral approach, essentially. So again, just like we just spoke about, the obvious advantage here is that there's no scar, but in my opinion, there may be anatomic advantages as to why the transoral approach may actually be better than the traditional approach, which I will show you in the next few slides here. It's controversial as to whether or not it's less invasive. The incision sizes are certainly very small, but the bottom line is there's no real downside to doing the transoral approach if you are an experienced transoral surgeon and have a lot of experience doing transoral thyroid surgery to begin with. So to talk about that anatomic advantage the transoral approach may have, let's review the recurrent laryngeal nerve anatomy a little bit. So here we see the recurrent laryngeal nerve in the tracheoesophageal groove coming anterior or superficial to the upper gland and posterior or deep to that lower gland. And so in the traditional approach, we have to come straight through this plane to get down to this upper parathyroid. Traditionally, the traditional approach, the nerve is pretty safe with the lower glands because the lower gland is usually so much higher up and away from the nerve. And this is just a lateral view of that. Here's the thyroid. Here's that upper gland. You see that recurrent laryngeal nerve running right up here, through here and into the thyroid cartilage. It can be very close to that upper gland. This is just another view of the same thing. The majority of upper glands are going to be found deep to the recurrent laryngeal nerve. The majority of lower glands is going to be found superficial to the recurrent laryngeal nerve. So what does this mean anatomically? in terms of the safety with the transoral approach. So let's talk about that. So here's a CT scan. You can see here that deep upper parathyroid, deep in the TE groove, almost back on the spine. So we have here is our right thyroid lobe, the parathyroid we just spoke about. There's the trachea and the esophagus. So in the traditional approach, you'd have to dig 5 centimeters deep just to get to that gland. And in addition to that, you're going to come right through the plane of the recurrent laryngeal nerve, because the recurrent laryngeal nerve, again, is anterior or superficial to this gland. It's going to be coming right between the thyroid and the gland. So in order to get to it with the traditional approach, we've got to come right through that plane of that nerve there, and puts it at risk. Here is the another view of that same thing, thyroid cartilage here. There's the right thyroid lobe, the subclavian artery. That's your esophagus. There's that parathyroid in the tracheo-esophageal groove. Now, here's the trajectory for the transoral approach. You can see it's coming across near that thyroid cartilage, but not at the bottom of the thyroid cartilage. Essentially what happens is the recurrent laryngeal nerve is going to wrap around the subclavian vessel and insert itself at the bottom of the thyroid cartilage. And you can see in this view, which is why this is so important, that you never traverse the plane of the recurrent nerve because of this anatomy. And that's in contrast to the traditional approach where you're going to come straight through that plane again. So this is the setup. It's the exact same setup that we use for transoral thyroid procedures. The only difference being that I don't put a 10 millimeter port in here. This can be done through a 5 millimeter port in the midline. That way you have less swelling, less bruising, almost none. A lot of these patients have no bruising or swelling after this operation. I typically do it with 3 5s, 5 here, here, and here. I have done it with 3 millimeter ports, which I'm going to show you a video of. These 3 millimeter ports are tiny and create almost no bruising or swelling at all. Okay, so let me show you how we do a parathyroidectomy with the transoral approach. So this is the same patient that we saw with the CT scan. So this is a right upper parathyroid deep down in that TE groove. As you can see, it's almost down on the spine. Here's that 5 millimeter port. We're going to use a 5 millimeter camera here. The parathyroid will come right through that port the majority of the times. If it doesn't come through the port itself, it'll come right through the tract with minimal problem. In this particular case where we're using 3 millimeter instruments, the only reason I even left in the port placement here is to show you these 3 millimeter instruments. They're very small. There's the Varus needle that we use to inject some saline. You can see that the Varus is almost the same size as these 3 millimeter ports. So this really is a minimally invasive procedure when you do it this way. Advantages of that are kind of questionable, I would guess, but it can be done with 3 millimeter ports instead of 3 5 millimeter ports. So here we've got the right thyroid lobe is pushed over the trachea now. We've obviously released the strap muscles from above. Here's the middle thyroid vein, an important landmark to help you find that parathyroid. Here's the nerve. You can see that little white line coming through right here. We're going to come a little bit closer to it. And here you can see it again right through here is a recurrent laryngeal nerve tucked up underneath the lobe, the right lobe of the thyroid. And you're going to see that the parathyroid is very far from this and it's lateral to it. And what we're showing you here is that you're not crossing through that plane like we were talking about. The nerve is going to run over in this direction. We're working out here lateral to it and away from the plane of the nerve. So obviously remember this is very deep down in the TE groove. We're continuing to dissect down, mostly with a blunt technique here. We're going to release some of this tissue again, pulling out. You can see the nerve over here, well away from our ligature. And now that parathyroid is going to come right out. And there it is, that parathyroid adenoma that we saw on the CT scan deep down by the spine. Very easy approach. Like I say, it can be done in under an hour once you get through the learning curve. There's its vascular pedicle. It's easily sealed with the ligature. Obviously, we'll take care not to get too close to the nerve when we do that, but you can see that the nerve is clearly far away from it. And then, of course, we have that very small one. So, in conclusion, we've been able to show that about 60% of all parathyroidectomies can be done with the transoral approach. What that means is if we routinely offered the transoral approach for parathyroid cases, that would increase the total number of transoral cases being done by about 30%, which is quite a lot, at least in the United States. In other countries, It may not be quite that since we do so many parathyroidectomies, but you're still talking about hundreds and hundreds of transoral cases that can be done that are very quick, very easy cases to do. In my opinion, the transoral procedure actually offers improved safety to the nerve due to better visibility and because of that anatomic change that I showed you that makes it even safer than it does through the traditional approach. And then, of course, it can be done with either 3 or 5 millimeter ports. Very minimally invasive. Most of the time, most patients don't even have any bruising or swelling, even with all 5 millimeter ports. So hopefully I've been able to convince you today that the transoral parathyroidectomy is a valid procedure and something that you should be thinking about, especially if you already know how to do the transoral thyroidectomy approach. It's something you can certainly offer for any parathyroids that come through your office that are well localized. Here's my information again. You can get in touch with me at rgrogan@bcm.edu if you have any questions about transoral parathyroidectomy at all. Like I said, I've done probably over 100 of them by now. I'm having a pretty good handle on it. I'm happy to talk to you about in further detail anytime. Thank you.